2040 comparative records. We are now on week 13. How exciting. It's a week before Thanksgiving. All right, so if you look at week 13 on your syllabus, you see we're going to cover chapter 16 and 17, other healthcare related settings. But if you look over at what we're actually going to accomplish this week, we have a discussion about cancer registry. Our assignment is critical thinking, question number 1 from chapter 16. And then we have a quiz over chapter 17. I'm not doing a lecture video for chapter 16 because it's really just there for you as knowledge base, and you're going to do your assignment on that question number 1 from chapter 16. So there won't be a lecture video on chapter 16, and you will not receive a quiz on chapter 16. But on chapter 17 you will, so that's why I'm here to do this lecture video on chapter 17 on cancer registry. All right, so let's move on here. We don't have any unit objectives this week that match up with this, and typically somebody may not have covered this chapter in the past when teaching this class, but I think it's really important for us to cover it because cancer registry is very much a field that HIT professionals can easily advance into and enjoy. So I want to cover it for you, for your future, in case this is an area of interest. Or in the future, you get down the road 5-10 years from now and you decide, oh, you know, I might like to become a certified tumor registrar. What is that all about? You've got this information and knowledge in your back pocket and can make that switch relatively easily. Before I jump in, though, I want to really quick talk about next week. Next week is week 14. It is Thanksgiving week, and I wish you all a very happy Thanksgiving. The only thing you will have next week is an online discussion about the future of classification systems. When we come back together, week 15, I will have a video lecture for you on the topic of classification systems and terminologies, and we will then get into that during week 15. So just wanted to give you that really quick. So moving back to chapter 17, our learning objectives according to our book are to explain the purpose and typical functions of a cancer registry, distinguish between population-based versus hospital-based versus specialty cancer registries, and describe key standards for cancer registries and cancer registry data. Let's fly through here and see what we can learn. Also we'll talk about key organizations, associations, and programs in cancer registry, including the Commission on Cancer, the National Cancer Registrars Association, the National Program of Cancer Registries, North American Association of Central Cancer Registries, which is an accrediting agency, and then Surveillance, Epidemiology, and End Result, or the SEER program. Oh, they have some more for us. We're going to also look at coding for cancer registry. So we'll be talking about how you use ICD-10-CM codes as well as ICD-O. And I think ICD-O is now up to version 3, for cancer registry data, including cancer staging. And then the certifications available for cancer registry professionals, the nature of quality improvement with cancer registry. So all of those. Terms. Cancer is a disease characterized by an uncontrolled growth of cells. It can be benign, it can be malignant. Typically when we say cancer, we're thinking malignancy, but it's basically uncontrolled growth of cells. Cancer registry, that is an information system designed to collect data on newly diagnosed cases and then follow them and monitoring the disease burden, the quality of care, survival, and disparities. Really, it's to help gather that data and report on that data, find trends, and those types of things. And you follow patients all the way through death. So types, there's population-based. This is a defined geographic area, and you use all sorts of data from any treatment facility, and then it goes through and it lists those. You also do death certificates and that sort of thing. Population-based cancer registries, the focus is usually public health and epidemiology, watching how that growth spreads and trends and that sort of thing. And every state in the United States has a statewide cancer registry. Notice that every state in the United States has a statewide cancer registry. All right, so types of cancer registries, moving on. You have your population-based, you also have a hospital-based one. Many hospitals choose to have one of these. They collect data for individual hospitals or networks of hospitals. The focus is on administration and clinical care. They evaluate if patients receive a standard of care treatment. They also help with research, and they look at cases. They do transmit data to the population-based registry as required by state or regional cancer reporting regulations. Then you have your specialty cancer registries. These are collecting data from specific facilities or a specific cancer site or familial meaning family cancers, hereditary cancers. They serve as an educational resource. They often have advocacy groups with them and a support system. The American College of Surgeons Commission on Cancer's National Cancer Database. This is an example of a specialized registry. It's really for outcomes and looks at cancer treatment trends, survival, quality improvement. Some examples of familial or site-specific cancer registries are like the Central Brain Tumor Registry, the Breast Cancer Family Registry, the Gilder-Radner Familial Ovarian Cancer Registry, National Familial Lung Cancer Registry. This is looking, they break off and they look at very specific types of cancers and really are drilling down into the treatments for those, what's effective, what's the survival rate, where are these cases being diagnosed, all of those. Who works in cancer registry? Well, HIM professionals absolutely are a part of this. Epidemiologists, information tech people, statisticians. Unfortunately, in the past, HIM professionals, not a lot of them have gone into cancer registries, so they've essentially taken untrained, minimally educated people and trained them up and put them up for certification by NCRA. As you can probably tell from my voice, my bias is HIT professionals need to be at the forefront of this. We have the training, we have the knowledge, we have the background, and there is a program where you can get dual certification through NCRA as well as AHIMA. They work together to build this program. And hopefully there'll be information about it at the end. But I would like to see more HIT professionals go into cancer registry. Regulatory issues, there are some standard setting organizations under the umbrella of that NAACCR set. There are uniform data standards for hospital-based and population-based cancer centers, and then you have the Commission on Cancer that was established by the American College of Surgeons that comes in and looks at cancer registry programs. So they look at hospital-based cancer registries. I have been through a couple of these surveys, so I'm very familiar with them. And they require that the hospital registry data pass quality data quality edits. They interview oncologists and nuclear medicine physicians who provide radiation therapy. They actually walk through, they sit in on cancer conferences, tumor conferences that are put on by the facility, and all sorts of other things. They look at a wide variety of things when they're doing their certification of the program. SEER is part of the National Cancer Institute. It's population-based cancer registry. Almost everybody, even though it's population-based, most hospitals submit data to SEER. They collect patient demographics, tumor site, morphology, and treatment. And it is the only population-based cancer registry with both longitudinal data on the stage of disease at diagnosis and survival. So SEER is very important and very popular. Then you have the National Cancer Registrars Association. They have the CTR credential. You have NAACCR, and they are the ones who come in and they accredit. I mean, you have certification by the Committee on Cancer from the American College of Surgeons, but you can also have accreditation, and this is through uniform data standards and that sort of thing. And they look at, and COC is hospital-based. NAACCR is population-based. So hopefully that kind of helps with that. So if it's hospital-based, you're going to be dealing with the American College of Surgeons, their Committee on Cancer. If you're a population-based registry, you're going to be dealing with NAACCR. So make sure you know those differences. CDC, we know that this is the CDC. They provide funding, data collection, and establishing standards for statewide population-based cancer registries, and they established the National Program of Cancer Registries. Abstracts, cancer abstracts, very familiar with this. This is the most important set of documents that are maintained by a cancer registry. It's the basis for all their registry operations. It's completed on all newly diagnosed cancer patients, and maintained electronically in the database. And these abstracts, they used to be paper where they would get filled out by the surgeon, the pathologist, and a couple of other people in the organization. Now it's all electronic, and it can be pushed to the appropriate provider. They can complete their information online and send it back. Categories of information, you have patient information, of course, and it has everything from demographics to their accession number, to their comorbidities and the physicians that are involved in their cancer care. The cancer information is all about the disease. When the facility first had contact with the patient, when the patient was initially diagnosed, the primary site of the cancer, its histology, behavior, laterality, grade, differentiation of the cells, and diagnostic confirmation details. You know, did they confirm it with PET scan? Did they confirm it with a biopsy? Did they confirm it with pathology? Did they confirm it with X-ray? Did they, you know, how was this all confirmed? The stage of the disease at diagnosis, they're looking at the size and local extension of the primary tumor. Was there any lymph node involvement, any distant mets or metastasis present when it was diagnosed? And then they really assess the pathology to know whether or not they needed neoadjuvant therapy or adjuvant therapy. So adjuvant, if you go back to your medical terminology classes, they're talking about chemo and radiation here. So they look at the pathology to see if the patient had chemo or radiation prior to the tumor being removed and being looked at through pathology. That helps them identify, are they going to need additional chemo or radiation, and that sort of thing. So that's what that last bullet means. Treatment, how was the cancer treated? Did they have surgery first, then chemo and radiation? Did they have radiation first, then surgery, then chemo and radiation? How did it all work? How was the cancer treated, and what was the first course of treatment? Was it one drug, and what was that drug? Was it a combination? Was it chemo and radiation? All those types of things. Outcomes. What was the outcome? When was the last date of contact with the patient? Did the patient die? If they did, where did they die? What was their cause of death? Was an autopsy performed? They also try and keep track of current address and phone number sometimes, that sort of thing for follow-up. Case administration, you have abstractor and reporting institution, coding manuals, coding systems that were used, text documentation, if there's something used to justify the code that was assigned, and sometimes summarizing the patient's cancer experience. Suspense cases, this is an abbreviated abstract. These are cases that may be included in the cancer registry, aren't currently, but they have the potential to possibly be. And then you have sources of information for suspense cases. Those are pathology reports or disease indices. These are patients that they haven't yet confirmed whether or not they're going to be in the cancer registry, but they're in suspense. They're held sort of in waiting mode to see if you're going to end up doing that. You might get some information, you might get a pathology report that makes you think, oh, this patient is going to be in the cancer registry. They're going to be a new patient in the cancer registry. But if you don't get any other information and the doctor says, hang on, we haven't yet done more testing or what have you to confirm it, that's when it's in suspense. It's not until after they have all of the information and have confirmed the diagnosis that the patient's going to actually go into the cancer registry. Okay, additional documentation. You have policies and procedure manuals. You have cancer or tumor committee meeting minutes. You have to keep attendance as who's there and the cases, the information, the background. There has to be a reporting manual if you're at a population-based cancer registry. Typically, these things are non-revenue generating. They're funded from a hospital budget or they're funded from a state budget, those types of things. They use ICD-0, that is International Classifications of Diseases for Oncology. Like I said, I think we're in the 3rd edition of that, so it should be ICD-0-3. But you also use some IC, and it says ICD-9 here. Shame on them. The copyright is 2018. We went to ICD-10 in 2015, so that should be ICD-10. But anyway, they may still be using ICD-9. They may not have made that jump yet, but they really should have, or need to do that in the future. But because they have so many years based on ICD-9, I can see where they may not have changed over quite yet. But just keep that in mind, that if you go into cancer registry, that may happen in the future. I don't know. And then SEER, you've got your coding rules and your case reportability requirements. The stage is the extent of the disease. It includes the tumor, whether or not it's locally spread, are there any involvement of regional lymph nodes, or metastasis. Think stage is TNM. Think of this, if you haven't studied this back from your medical terminology days, stage is TNM, tumor, nodes, metastasis. That's what you're looking at to figure out the stage or the extent of the disease. The grade of the tumor is how well differentiated, and they don't go into grade here, unfortunately, but the grade is how well differentiated the cells are, how diffuse they are, how just how aggressive it's going to be. So that's where you've got stage and grade. The stage is typically done by the surgeon or the oncologist, and oftentimes they'll use a PET scan in addition to op reports and other information to determine stage. The grade is always determined by the pathologist, just FYI. Okay, so ways you can assess stage of the disease. You've got the American Joint Commission or Joint Committee for Cancer Staging System, or AJCC. You've got SEER, and then you've got a collaborative staging data collection system. So these are all different tools that you use for assessing the stage of disease. Cancer treatment is going to depend on the type and stage of cancer. Is this treatment going to be curative or palliative? Because there comes a point in time where curative just isn't working, and you have to move to palliative or have that conversation, and that sort of thing. And then we talked about options, including surgery, radiation, chemo, hormonal therapy, which is also considered chemo, immunotherapy, which is also considered chemo, transplant, and endocrine procedures. So coding rules and data elements, you've got FORDS, SEER, and NAACCR standards, the data standards, data dictionary. Those are places that you can go to find out about coding rules and data elements for cancer registries. Information and flow, you've got hospital-based sources for case finding. We talked about pathology reports, disease indices and discharges. That's from coding data. Typically, cancer registries have these reports that come out of the EHR. They're pulled out of the database that contains all the diagnosis, procedure, all the coding information, and they have reports that are set up to print in the cancer registry. They can be set up to print once a month or twice a month or weekly, or however they want them to print out. Pathology reports and other types of lab reports, those reports can come out directly from the lab system. You have medical and radiation oncology logs that are kept, outpatient records, diagnostic radiology reports, those come from the radiology system, the RIS system, and then you have potential cases that are in your suspense. Hospital-based, you abstract your cases concurrently as the data becomes available, or you may wait two or more months before abstracting the case. It just depends. When the case is completed, it's sent to the Central Cancer Registry as well as to the National Cancer Database. And then you've got population sources of data. Those are coming in from hospitals, pathology labs, private clinics, ambulatory surgery centers, radiation centers, oncology clinics, death certificates, nursing homes, hospices, out-of-state cancer registries and facilities. It's all coming in from all different directions. And once the case is complete and all data is linked, edited, quality controlled, reports go to the NPCR, SEER, and NACCR. So software, there's a lot of electronic systems. Microsoft uses SQL reports. Oracle uses databases. There's Sybase, there's MySQL, Postgres. These are all databases with reporting systems that you can pull information out. You definitely need a database management system, and they recommend using this GIS to map the data. Confidential data sets are based on standards developed by NNEA CCR. Data exchange has been developed by them for producing data sets for exchanging data between population-based cancer registries. These data sets are constructed based on how the data will be used. And then in terms of quality improvement, utilization management, you've got the COC, SEER, and NPCR that are requiring edits to ensure codes are valid and code combinations make sense. Then COC requires quality control plans and quality measures, looking at not only the data, but also patient care. Then you've got hospital-based cancer registries that the COC, they've approved hospitals to submit data to the NCDB, National Cancer Database. They are doing this to compare their treatment and outcomes locally, regionally, and nationally. And most places that have cancer registries, when they start a cancer registry, within the first 5 years, they want to get that COC certification. And it takes a few years to be able to do that. It's not something you can do within 1 year. It usually takes a couple of years, but that's when they start those, they usually want to get that jump and get that going and become certified. Population-based cancer registry information is used to develop cancer control programs, monitor the disease burden, how this differs between different groups and population, and that's where you get into some of your disparities, health disparities. They study causes of cancer, and then I just talked about disparities. Patients do not consent to collection of their cancer data information. They don't have to, and they really can't, because this is all under law. All of these laws have basically made it so that cancer data is collected, whether patients like it or not. So what is the role of the health information management professional? Well, you can get a CTR credential from NCRA, and that is required for most cancer registry positions. I would not suggest getting into cancer registry unless you're working toward your CTR. And know that you're going to need to get that to stay in a cancer registry position. There's a variety of rules, because depending on how large the cancer registry is, they may break these out, or and depending on how small or large one organization is, you may find 2 or 3 people doing all of these things. And then trends. This is they're trying to get usable data more quickly. They're trying to do concurrent abstracting at the hospital level. They've really pushed that from retrospective abstracting to concurrent. So that's the biggest trend that's out there now. Population-based is using rapid case reporting. EMRs now have cancer reporting menus in them, and they're trying to gather real-time electronic pathology reporting. So in summary, cancer registries can be hospital or population-based. They provide valuable data on treatment outcomes, survival rates. They provide career opportunities for HIM grads who are willing to meet the eligibility requirements and take that CTR exam. And of course, you will pass. If you study, you will pass easily. And this gives you some web activities if you're interested in going out and looking at some more things with that. And that is it for cancer registry. And this ends what we are doing in our book, and so moving forward we'll be talking about terminologies and classification systems, and that'll be week 15, and I'll be back with more information for you about that. So take care, and I will talk to you again soon. Bye.